So let's start with Matthieu.
Good morning, everyone. Thank you very much for the invitation. I'm very happy to be among you, even remotely, and to talk about kidney protection. Um, let's start. Sorry. So the common belief is that there is no available intervention to protect the kidney. The question is that really true? And I'll try in the next 15 minutes to show you that actually the kidney protection is probably one of the most evidence-based reality in the field of perioperative care or ICU patients. And I'll start actually not by the kidney, but by the lung. And you know that over the last 20 years, we have been an increased evidence that we can cause harm and damage to the lung, especially with too aggressive intervention, including, for example, high volume, high tidal volume, and that a protective strategy for the lung was associated with better outcomes, especially in the ICU patient, but also in the operating room. And actually, the kidney also have been under investigation for a lot of interventions, which were shown to be associated with damage. So clearly, I'll show you some very good evidence that, like for the lung, the kidney, the way we treat our patient can impact the kidney and damage the kidney. One, probably the most known one, is the use of torches especially in the ICU, but more recently also in the operating room. I won't go further because I think that a bit behind us now. But obviously, the use of this fluid solution was associated with a higher risk of kidney injury and probably also mortality, especially in the ICU patient, but also with a flash study in the OR. A bit more recently, a focus on the use of crystalloids and saline compared to balanced solutions. Even if the debate is still open, we still have very strong evidence actually that using saline as a only a solution, especially in ICU patients, is associated with a higher risk of kidney damage. And there is actually a good pathophysiological background on that, with a vasoconstrictive effect of chloride on the afferent arteriole of the glomerulus, and also the development of metabolic acidosis associated with hyperchloremia, which could trigger the initiation of renal replacement therapy. And been several, actually at least two in the one in the ED, one in the ICU, cluster randomized trial investigating the use of balanced solutions, so ringolectate or plasmate over saline in those patients. So cluster randomized trial is the patients were not randomized, but the units were randomized. And here you can see, for example, 5 in this trial published in the New England Journal of Medicine a few years ago. 5 units, and each unit was switching the solution every month, and 5 ICU, 1 center, and switching 1 month saline, the other month balanced solution, and so on and so on. The results of this cluster randomized trial was that saline was associated with a higher risk of major adverse kidney events at day 30, defined as the need for renal replacement therapy, persistent renal dysfunction, and or death within the 30 days. Of course, the effect size was low and number of patients to treat was high, 94. But I mean, that's kind of expected, and luckily, I mean, that will be a dramatic if saline will cause a major adverse event in all our patients. Of course, so the effect size is expected to be low. It is low, but still, we find some intervention that could be considered as minor. I mean, the choice of balanced versus saline solution to be impactful on the kidney outcomes in ICU patients. There are more study to come, but that I mean there is no much much intervention or a strategy in ICU patient in the OR would have been shown to improve outcomes, and this is one of them. Of course, the impact of hemodynamics on the kidney perfusion and kidney outcomes. You know, that especially patients with hypertensive, chronic hypertension, past medical history of hypertension can have a shift of the autoregulation curve to the right and need higher perfusion pressure to maintain both the renal blood flow and the GFR. Here, a physiological study very well illustrating the impact of the renal perfusion pressure using norepinephrine in post-cardiac surgery patients. And you can see that here the GFR was measured at different mean arterial pressure using norepinephrine, and many patients actually increase their GFR while raising the mean arterial pressure from 60 to 75. And some of them further increased their GFR with higher mean arterial pressure, while some of them decline the GFR, suggesting that there is a very wide variability in the renal response to pressures and the right and the good target for the renal perfusion pressure in our patient that needs to be individualized. And this concept of individualization was very nicely put in a randomized control trial by Emmanuel and colleagues in the IMPRESS trial, where the patient were randomized to two different levels of mean arterial pressure, kind of standard of care, and the other one was to target the systolic blood pressure within 10% of the baseline that was measured in the prepare clinics. And targeting kind of the baseline systolic arterial pressure in this population of patients undergoing major abdominal surgery was associated actually with a decreased risk of renal dysfunction, with a small number needed to treat actually in this population. That was one of the outcome in the primary composite outcome. Other setting, cardiac surgery, a randomized trial by Alexander Zaborg and colleagues in Germany, that the Prevaki trial, where patients were randomized to receive standard of care or a bundle of interventions that was expected to protect the kidney from damage and acute kidney injury after cardiac surgery. And you see that the patients receiving the intervention had lower incidence of acute kidney injury and moderate or severe acute kidney injury in red compared to the control group. So the bundle was association of different intervention, mostly hemodynamic optimization using dobutamine, either cardiac output was too low, but also avoidance of any nephrotoxics. When we look at what was the main intervention in the control in the intervention group, that was mostly actually a much higher use of dobutamine, and that was associated with a surrogate of better systemic perfusion and a higher cardiac output. Also, better control of better glycemic control, and that could be discussed. I'm not very convinced on this one, but also lower use of ACE inhibitor and ARB in the post-op period when patients were selected of having high risk of AKI based on biomarkers. This study, actually, the same design was replicated in a multi-center design still in Germany by the same authors. And so that was a Prevaki multi-center randomized control trial, same intervention, same setting, post-cardiac surgery patients. And here, actually, among the different intervention in the button, mostly the dobutamine was different. The other Other interventions were not much different. Actually, the fluid were a bit higher, but not significant. No difference in hyperglycemia, ACE inhibitor, or diuretics, probably because the way we provide those interventions evolved over the years and between the two studies. But anyway, the author kind of found the same results, except that they didn't find a significant association with AKI, but still observe a protection toward moderate or severe AKI in patients enrolled in the intervention trial. So mostly patients who receive more often dobutamine and acting on the hypoperfusion part of the kidney injury in those patients. So obviously, there is strong evidence from randomized controlled trial and high quality studies that the care we provide impacts renal outcomes in our patients. And more recently, actually, that's not interventional study, but there is indirect evidence during the COVID pandemic that the way we treat our patients impacts outcomes, and especially renal outcomes. This is a large observational retrospective study based on the VA, so the Veteran Affairs in US. And you see here the incidence of AKI among COVID patients in different centers. And you can see that the incidence can vary from 10 to more than 60% in those patients. There could be some variation, of course, of baseline characteristics of patients, but that cannot explain all the difference that was observed. And when we look at, then when they look, at the incidence over time of COVID associated with AKI, the system from March, so the beginning of the pandemic, to July, actually, the author observed a true decline in the rate of severe AKI in COVID patients. So there is obviously an impact on the way we treat and we care for our patients on the incidence of AKI. It's very hard here. We have some hypotheses. It's very hard to know exactly what was the true reason why the incidence declined. We can discuss that later, but still there's some data. And when we look at the impact of the centers and how even a small intervention can impact AKI rate, actually that was a study we did in our former unit in Saint Louis in Paris. We had an outbreak of Acinetobacter baumannii in our burn center, and we compared the rate of AKI and major adverse events before the outbreak and after the outbreak. And the major difference between the two, before the outbreak, and during the outbreak. And the major difference during the outbreak was a much higher use of colistin to treat those infections. And what we observed, for example, was first that we observed a much higher incidence of acute kidney injury and persistent acute kidney injury and MAKE during the outbreak than before the outbreak. And using machine learning analysis, colistin was associated very strongly with a higher incidence of MAKE and acute kidney injury. So there is clearly a center effect, and depending on the treatment we give to our patient, the way we ventilate the patient and etc., can impact clearly the rate of AKI. And also the way actually we care for AKI also impact actually potentially the recovery from AKI. I like very much the study, and to be honest, also big congratulations to Stéphane Godouy and his group for very actively working on that topic. And this, I want to present all those data, but I will present one of the latest ones, that the START AKI trial was published a few months ago in the New England Journal of Medicine. Strategy of early initiation versus more conservative initiation, accelerated or standard initiation of renal replacement therapy in patients with AKI in the ICU. And outcome, the mortality, the primary outcome was not different, but very interestingly, actually, the patients who were alive at day 90 at a higher dependence, 74% higher dependence of renal replacement therapy when they were randomized in the accelerated strategy group versus the standard strategy group, which means that maybe being a bit too early, a bit more too liberal in the use of renal replacement therapy can impact renal recovery and increase the risk of renal replacement therapy of dialysis dependency in those patients when they survive. And of course, remember, that would be my last word, that AKI is a syndrome and is very rarely the primary and the only issue in the ICU or surgical patients. And it's most of the time a bystander and a victim of another disease, and the best way to prevent or treat AKI is still to fix the cause and then to avoid any further additional damage, infection, obstruction, thrombotic microangiopathy, etc., should be treated, and we should not lose this target when thinking about AKI. So the take-home message will be, yes, we can protect the kidneys. There is actually a lot of and major evidence that the way we care for our patients, the way we apply, we intervene in our patient impacts AKI, and we can protect the kidney using a wide choice, potential damaging or invasive interventions in the ICU or in the OR. I thank you very much for your attention, and we'll be happy to take questions if you have afterwards. Thank you very much, and once again, thank you very much for the organizing committee for inviting me.
Great talk, Matthieu. Thank you very much. So I really like your ending, because you have talked about many very physiological issues, blood pressure and fluid challenge, and you ended with this great picture of bladder retention. So never forget the basics. And I will have a question to you. It's you have talked about blood pressure, fluid challenge, etc. And also don't forget the nephrotoxic antibiotics. And don't you think that in septic patients, such as patients with peritonitis, we may use too often nephrotoxic antibiotics for non-very severe patients? Don't you think that we could reduce that?
Oh yeah. Thank you, Gerald. Yeah, that's actually a key question and a great question. For sure, we use much more, too much antibiotics, too often antibiotics, too long antibiotics for too long, and among them a lot of toxics. It's hard to resist when you have a severe patient. The patient with septic shock is very hard to resist not adding antibiotics and a very, very broad spectrum antibiotics. But probably the best we can do is to de-escalate as soon as we can, and really every day we should think about stopping sedation, about weaning the patient from the vent, and we should every day think about how much am I damaging the kidneys, and using potential nephrotoxic like aminoglycosides. In Europe, in US, would be a lot of vancomycin, or even was an association between vancomycin and tazobactam. So yes, I fully agree. Too much and too long.
Okay, so maybe at day one in the operating room, but day two in the ICU, if everything is controlled, we could stop these nephrotoxic antibiotics. Okay, and my last question, it's what's your opinion about all you have talked about, all these interventions we have to do in your experience, France and in the US? The biggest problem we should take care of.
You mean for protecting the kidney?
Yes, in the operating room.
in the OR, I would say evil is in the details. So unlikely there is one big intervention that would protect the kidney. The addition of small protection. First of all, of course, treating the initial condition leading to acute kidney injury, and then be careful about mean arterial pressure, which is more complicated than we think, actually, maintaining baseline arterial pressure and wisely using fluids over vasopressors. And that actually requires a lot of attention and a lot of dedication by the team to kind of optimize the hemodynamics. But for sure, hemodynamics is a key one, preventing both hypoperfusion, but then congestion later on, nephrotoxics, and it's about. We were talking about, for example, the COVID patients. I didn't mention that in the presentation, but clearly, I think one of the reasons why AKI declined over time, it was because we used more wisely, probably mechanical ventilation too during the pandemic. So it's really details, but hemodynamics and being very precautious with all intervention that could damage the kidney, from antibiotics, too much fluids, too less fluids, and too aggressive intervention, including mechanical ventilation.
So thank you. It's a very wise recommendation. So not only one trick, only one recipe, but think about the big picture. And we are going to see if Matthieu Jabaudon agrees with you. If too much fluid challenge to protect the kidney would impair the lungs.